They're really reliable enough for developing risk scores.
Thank you very much, Professor Gumbert. Dear Chair, dear ladies and gentlemen, I thought it would be an easy task to go over and say whether clinical databases are really reliable enough to produce some risk adjustment tools. First of all, we have to think about clinical databases. As seen in the very first speech, there are always used administrative data in there. This is a first step. You can go just to take the administrative data which are available. They include demographic variables. They have some dates of admission, of operation and discharge. They have even the discharge status, which indicates whether the patient is alive or not. And the main diagnosis and main procedure may be in there. And countries where DRG-related systems are included, you have also the DRG information available. The second step of databases is a so-called specified database. You have administrative data plus more specific information about the patient, which means you may have some existing score variables in there. This is better. But you may also have some study-specific variables in there for some studies which are currently done or which have been done in the past where the variables are still in the database, but you also can have only some calculated score values which are not very helpful if you do some score building. The best way to perform a database is to do a scientific database where you have administrative data plus various information, like variables used to extract the information for different scoring systems. We have some variables actually not part of any score so that you can really try to generate new knowledge. This is a goal you have to think about if you're preparing a clinical score. First of all, most scores they try to apply for a clinical application, which means a bedside application, to get some kind of objective tool for risk assessment. The second one is a risk assessment itself for risk adjustment. And this is done for international or national quality assurance properties. It's a very fast and simple way of risk certification where you have a limited number of variables which are encountered. And third, you have the science with generation of new knowledge, which should be the effort to do. Scores will require a lot of consideration about, first, the goal. Which is the goal you are heading for if you create a score? The event may be just defined as cardiac mortality, total mortality, or even morbidity, as we have heard. The investigation interval is extremely important, and if you say you are looking for 30-day mortality, this is not the same as 30-day hospital mortality as used, for example, by the Euroscore. A further issue is the population. If you plan to go for subgroups like isolated CABG or isolated aortic valve repair or replacement, and extremely important is also the era where you choose your patients from. Whether you take into account some intervals like 10 years, 1 year, 1 month, it depends highly on your results now. Further, the variables need a very clear definition, as already mentioned before. You need a clear selection of variables, a very fine definition. You have to look for interactions, for transformations of the data, and you have to know whether and how to use your missing values, which are mostly included there. The next step you have to think about are new and alternative techniques which may come up even after building your score. This is quite, very hard to reflect, but sometimes you get some information from industry or related things where you can perhaps expect to have some changes in a very short time. And the last point is the generalization properties. If you try to publish your score, you should be able to think ahead your score, which you produce yourself, and to know whether or not other institutions may have the same result. If we are now looking to the investigation interval a little bit closer, it seems to be that 30 days, the 30-day interval is quite very nice, and it covers the majority of patients. Well, here it covers the vast majority of patients if you're looking to a 6-month interval. This is only the time to discharge. However, if you're looking to in-hospital mortality, these are quite the same data, but if you're now restricting to in-hospital mortality, you see these 30 days, they cover even only 85% or something like that from the total mortality, even from the hospital mortality. I'm not talking here from the really total mortality, but it's only the in-hospital mortality. This is quite a really striking thing. If you're looking here, it's a really big disadvantage of hospital mortality only. And if we're comparing now versus this total 30-day mortality, you see here a large difference between these points. This has been a database of a very large patient group, and we just combined it, and it was a very large interval. Also, it was a interval of 15 years, so these data are quite high, but you see a clear difference of total mortality versus in-hospital mortality even after 30 days after surgery. So, in-hospital mortality allows us very simple application of administrative data. You have no additional work. However, it depends highly on discharge policy versus 30-day mortality. The follow-up procedure requires additional work. However, it reflects the truth. And you have higher mortality numbers, which are nowadays a bad marketing tool, but it's the truth and it's more scientific. And if we're looking now at the variables in this course, you need a very careful modeling, which means if you have two linear or quite linear behaviors, it's very important to focus which one you take, and you have to take into account many things. Here, for example, you have the issue of insulin-dependent diabetes, and if we are looking, it was a very high mortality in the early 90s, which dropped down by neutralization of the variable itself to a mortality of about 4% in the most recent group. So these are considerations you have to make before you really create your score. This is also expressed by the area under curve. If you're looking for the Euro score, how it performs over time in the same type of subgroup of patients, you see it's dropping down as already mentioned before, and it's really dropping down to values which are unacceptable. If you're looking to the prediction, this was the issue before, I show you here two different scores. First of all, on the Euro score for the era before the year 2000, and it was already there an overestimation of risk for, it was an isolated CABG patient group. The KCH score was a German National Quality Assurance score, which was built in 2003, and there was, at this point for this earlier group, an underestimation of risk. However, if you take the era from 2000 to 2007, it's even in this score a high overestimation of mortality. It's even getting worse and perhaps even more complex if you go to the established scores like the Euro score, which indicates 3 different risk groups. It was in the very original publication where 3 risk groups has been established. It's a little bit confusing even to me that even in the early group from 1994 to 1997, in this subset of patients with isolated aortic valve replacement, if you see the expected mortality here from the score is 8.1% versus an observed mortality of 3.7%, which means about 5% overestimation. And this is quite stable through the whole group until 2006. So it may be some issue about the subgroups. The problems of scores we face, that they are always based on historic data. They are very often unspecific. That means they include total cardiac surgery and not special subgroups. We have an arbitrary endpoint of 30-day hospital mortality in most of the scores which are available. We have a simplification of complex biological systems, as shown before, and we do face a neutralization of variables, and we need multiple versions after recalibration, which makes it very complex even to compare groups over years. However, it is very nice to use scores if you're going, for example, to your administration and you have to show why your amount of money you spend on the patient is getting higher. If you present them that your high-risk group is just increasing, they will be very happy. And this is really a very helpful tool you can take in your institution. So you need a categorization of patients by score. This is easily done. So it's really useful for illustration of time-related changes. However, it is limited useful for interinstitutional or institutional comparisons. It's absolutely insufficient for individual risk assessment, and it's also insufficient for individual therapeutic decisions. The individual prediction is possible, as shown years ago. You need a scientific database, you need an extreme high data quality, you need a complete follow-up of the total patient group, you need complex mathematical calculations, not only simple logistic regression, you need a very careful validation, and you need regular recalculations. This has been a group of patients about 15 years. It was calculated by the parametric time-adjusted hazard function with a scientific database behind there. It was about 10,000 patients, which we investigated, and you see it really nicely fits to the Kaplan-Meier survival curve. And you can here include even years for intervals, which is much more meaningful, but 30 days after operation. So our clinical database is reliable enough for developing risk scores. This was the original question. From the viewpoint of the statistician, for sure, yes, if several requirements are respected. From a viewpoint of a surgeon, yes, with a very big and large but. Thank you very much for your attention.
Thank you very much, Bohdan.
I would like to congratulate on this very informative and I think very important talk. I think there is never too much time to talk about how 30-day mortality weak is as a measure of the postoperative outcome. We still measure both 30 and hospital. And in congenital heart surgery, the mortality after 30 days is so important, is so big still. ECMO, VAD, modern intensive care, to keep patient alive until 30 days is something. And also the courses, expected postoperative course in a very, very complex patients. 30 days, it's now quite a regular thing. That's one thing, so congratulations. The second thing, the problem with the scores and the time. I would like to support this, what you said, enormously, because if you look at the outcomes in neonatal congenital heart surgery, in the huge case mixes, 10 years ago, the open heart, the mortality for open heart neonate was close to 30%. It's 8% now. It's a different era. It's different. So we need to reevaluate, and we need to reevaluate the scores and update the scores probably every second year to make them realistic. Congratulations, a great talk.
Okay, we have time for two very short questions because we are already 15 minutes behind.
Joseph Regata from Lisbon. This is just in continuation what Dr. Maruzewski just stated. If this is important for the pediatric population, it's even more important for the adult population. We do keep a database on patients, discharged adult patients, and I can assure you that 30-day mortality gives you only a small glimpse of what actually is happening afterwards. So, I mean, raising the point, shouldn't we increase this surgical-related mortality to 3 or 6 months? And I think this is very pertinent because, especially if you're working on an elderly population, more and more people actually die after leaving the hospital.
That's true, and what we have seen, a cutoff point would be at least today, about 90 days, but you never know what happens years after. So we were looking regularly in our institution, at least for 180 days, which covered most.
Thank you.
Okay, Fred, please.
Yeah, just to say one more point, I really agree with what Rosiewski just said. I think you need to update the risk models every year because the risk of surgery changes virtually every year to be really accurate and not behind. The other thing is, Fred Edwards might want to comment on this, maybe not right now, but we believe too that you need to go beyond the 30 days if you can. In the VA, we've been collecting data for at least 180 days. And Fred's working now with, we have a bigger problem in the U.S. because of HIPAA with patient identifiers and the confidentiality, but we really want to track these out long term so we can be comparing the long-term efficacy of coronary bypass, for example, against stents, that type of thing, and certain patient risk subsets.
Okay, well, thank you very much, Oswald. And I have the pleasure now to invite Paul Sergent to give his talk. What is the ideal database, or how to build it?
What is there to say after these very intelligent individuals who have just spoken and these very brilliant presentations? I'll try not to repeat what they have said. Most of the content of what has been said this morning has been included in an e-learning module that is already loaded on CTSNet. It's a closed e-learning module about data, methods and variables and censoring, and Brigitte has collaborated, and it has been published already in 8 languages, so the e-learning module is in 8 languages, and we're working on a Japanese translation, and we're working on a Russian translation also. Society and patient can only allow the aggression of the physical integrity of the patient under a positive proof of cost-benefit. So medical professionals have to show patients and society that they allow this in-depth analysis of the type and quality of care, conditional, of course, of the appropriate scientific, legal, and privacy requirements. So who should do it? Should we do it ourselves? Of course, then we're Indian and cowboys at the same time. Should we do the media? And you've seen some of the pictures before. There have been dramatic experiences in several countries. And of course, the media have no knowledge at all about pathology, variability, and the basic science of outcome analysis. Governments, well, we're a little bit scared about governments because outcome analysis is a science, as Brigitte has very clearly identified this, and outcome analysis has nothing to do with politics. And scientific organizations, well, there's a lot of politics within scientific organizations, Bogdan and me. We have identified that over the years. But science needs to be done by scientists who have the required knowledge. What is supraregional quality control? Quality control is the process of identifying centers and individuals who are underperforming. And performance is analyzed in a scientifically correct manner, including correction for patient procedure and institutional variability, and also including the analysis of the uncertainty. Quality control has the equal respect for the privacy of the patient, the medical practitioner, and the institution. Quality control has nothing to do with ranking. Absolutely. I mean, we know that from the UCI ranking in cycling, as I said during my presidential address. I mean, there's nothing as stupid as the UCI ranking. And databases are just a tool to evaluate quality. It has been commented. There's issues about on-site visits, guideline practices, how they are reported, the use of resources, and the use of training. And databases are, of course, no finality. Neither is their creation, their maintenance, or their publication. What are the quality criteria for a quality control database? Well, you have to define a region, you have to define a cardiothoracic surgical pathology, define a finality, use the law to protect your project, define participation agreement of all involved parties, define an ad hoc inclusion interval, define ad hoc outcome events and intervals and define ad hoc variables in relationship to outcome events. As Brigitte has just said, you cannot expect that one set of variables will cover the whole complexity of medicine and cardiac care that is done. And even within coronary surgery, as an example, the standard variables today do not cover the variables, because we are treating patients today in cardiac massage. We're treating patients just minutes or hours after a lung transplantation or after a very severe or after a mass casualty. We're treating these patients, and these are exceptional conditions with sometimes exceptional mortality, and they have to be corrected for, because that's the fundamental basis of the analysis. And once you identify negative outliers, and that does not mean negative performance, it just means negative outliers, you then starts quality control, because then you have to go to these units. It has been identified already before, analyze in depth the cause and the processes of these outliers. It could be very valid reasons. Do not forget to use the law to protect your database. As soon as one starts recording data, data will be manipulated and cheated on. We've learned this from the banks in the last 2-3 years. We've learned this from governments also in the last 2-3 years. And we know this, of course, from sports. And I've forgotten to mention the word medicine, but we all know where it should stand for. The legal deposition of a finality protects the misuse of a database. In Europe, we have laws. I mean, English is a little bit a special situation. England is a little bit special situation. But for example, in my own country, once you define the finality of an electronic database, that cannot be changed. You cannot, whenever you misuse that. If I give my name and dates of birth to Coca-Cola, and they give it to sell, a company to sell cars, they're in the illegality, and they will be fined for it. So it's very well define your, protect your database using the legal environments that are made possible, certainly in most of the European countries. Please excuse me for that. It's just telling me my next obligation. Even leadership of a scientific organization has no understanding of outcome science. You must understand that the criteria for outcome, for leadership in an organization are not the same as those for outcome analysis. There's no evidence that publication of risk tables by surgeon institutions improve the quality of care, and we'll come to that in a second. We must register all variability. If we want to correct for all variability, we must register for all variability. And there's a lot of spectra of risks that there are: age, gender, race, genes, cerebral reserves, cardiac reserves, pulmonary reserves, hepatic reserves, and it continues physical reserves. Now, we never register physical reserves. We have often no idea of the oncological status of the patient. I can tell you that if you follow up patients, as we have done, we've followed 20,000 patients for more than 20 years, you discover that you've done 4 arterial anastomosis, and that 3 months later this patient is dead because you've missed the fact that he was having an active cancer at the time. That's what you learn when you do long-term follow-up. And of course this variability is deposited in variables. The reason why I created this plot is precisely because there's something called the ASEF score. The ASEF score uses only 3 variables. It had been proposed by Marco Ranucci. And the cardiologists have now picked it up because it's very easy. It's just 3 variables. And they say, well, the areas under the curve also reach 0.79, as Brigitte has just talked about. Well, it means that they're equally good. Well, it also means maybe that they're equally bad, because most of the scoring systems, if you only reach an area under the curve of 0.80, it means that you still have an enormous surface that you're missing. Why are they up to 0.80? Because they're very good predicting of the survivors, but we're all interested in the predicting of those that will die. And even at the pivotal value of a risk score, they usually fail very badly. Please plot your pivotal values at the best. With pivotal value is the value that has the best predictive value. Look at how bad you are in predicting those that will die. When I mention registering all the variables, this is the pH of the patient at the time of entry into the operating theater. We have operated hundreds of patients in cardiac massage, in cardiopulmonary resuscitation. And I can tell you none of the traditional values have any predictive value. The value with the single most predictive value is the pH at the time of entry into the operating theater. So if you include in your data set, some countries, they never do patients in cardiac massage. If you include in your data set, you need totally other variables than the standardized ones. So this means you will need to have biological variables. There's a lot of variability that we're missing in the scoring system, and that's precisely why very often they are so bad in their areas under the curve. and as Brigitte has just identified, the correct observation interval. The three pictures on the back, on the lowest part of the slide, are each time an indication of the size of the coast. And as you know, you need to know when are you going to measure that coast. Are you going to measure it at high tide or low tide? And they're very different observations. The problem with the observation interval, and Bogdan has already addressed that. And it becomes very critical when you start comparing therapies. And we've learned that from the syntax where they made the mistake in the incorrect observation intervals. You cannot just talk about 30 days. On the left-hand side, you see the risk interval of stroke after coronary surgery, and it lasts for around 10 to 12 days. Anything outside of that interval is going to be influenced by other variables. If you look at the risk of infarct after coronary surgery, it's within the first 5 days. If you talk about the risk of re-intervention after coronary surgery, it's within the first 30 hours. If you talk about the return of angina after coronary surgery and you want to observe the early risk, you have to go up to 15, 16 months. The data will tell you what the observation interval. We absolutely have to stop using the 30-day interval. Whoever came up with that idea of the 30-day interval, I mean, he should be confronted with what the science is of outcome analysis. We've been lucky that we had Blackstone and Kirkland telling us these things and forcing it upon it. Hospital stay is a time-related event. We have to study this in a time-related manner, as has been shown in the previous presentations. Follow-up methodologies. Most of the publications give us no idea what follow-up methodology has been used. And if you want to correct scoring systems, you have to correct scoring systems. You have to identify on what basis. For example, in the Euroscore, we have no information, and I know I can sing the original Euroscore presentation manuscripts. There's no information how complete the data was up to 30 days. In fact, the original variable of 30-day mortality was never accurately described. And as has just been shown, there's a wide variability in interpretation. Public reporting. I know that there is a difference of opinion between the United Kingdom and most of the other countries. Professor Geras from Witten has made a very interesting report that he published and then that he presented not so long ago based on 45 studies about the effect of public reporting. He concluded it's a very interesting study that is more negative versus positive effects. And he says the effects, and he put eight issues about public reporting: tunnel vision, sub-optimization, short-sightedness, fixation on the sample size, false reporting, misinterpretation, gaming, and ossification. He explains that very well. And I think there's a lot of issues about that. I personally am not excited about public reporting. That's not how the way should be done, because the media cannot interpret. It's already so difficult within the leadership of the scientific organizations that the media can interpret that. Certainly if you use then the wrong observation intervals and you have not corrected for all this variability. In conclusion, I'm very much in favor of to perform supra-regional quality control, but please understand that none of the presentations I have seen today has anything to do with quality. They have all to do with risk. And quality has nothing to do with an early interval. Quality is the observation of how your procedure has influenced the complete life expectancy of the patient. Position this project within a scientific organization. Protect your project against non-scientific influence. Very difficult. I have personally failed on a number of these issues. So, and I regret that for the rest of my career. Define a medical and regional domain. Define a finality. Accept simple and easy finalities to start, and accept that you analyze risk and not quality. I thank you.
Well, Paul, thank you very much for this very important comments, questions, remarks. Ben, please.
I guess you'd expect me to stand up and justify the UK position on this one a little bit. The thing that I see now about public reporting is that what public reporting absolutely has done is it's driven complete data collection. So before we were reporting, we had maybe 80% of units who were collecting data, and we maybe 20% of units who weren't collecting data, and data collection wasn't complete, and it wasn't fit for any purposes of quality improvement. And intervention by the media, which was managed by the professionals, led to a situation where we do get complete data capture. And to me, that's the only important bit of the public reporting agenda, is driving complete data collection. I think the subset of that, which I alluded to a little bit in my talk, is how do you utilize this data for maintenance of public trust? And to some extent, there needs to be public reporting. It doesn't necessarily need to be reporting of the absolute data. Perhaps it's reporting and education around the systems which are in place to deserve that trust. But that's an absolutely important fundamental point of public reporting, in my opinion.
I think, Ben, I consider you one of my friends, but one of the aspects is that you're absolutely right. You now have complete reporting of the data. The problem is the interval is incorrect, and at the same, so it's not about quality, it's about risk, and even you don't monitor the risk. You have the complete data of the risk, but it's not even the complete risk. It's only part of the risk. So, and it's only the incomplete list of variables, because. And the gaming has been known in the United Kingdom, that there is gaming, that some patients have been, you know, it's not your intention, but it's the reality that when I talk about centers, I go repeatedly to the UK to talk about these things, and I ask, how many patients have you ever done in cardiac massage? And they say, we don't do patients in cardiac massage. And I said, well, I mean, if you have a 50-year-old man and he's in cardiac massage in the cath lab, I mean, what do you do with it? We just stop. And he said, and the reason we stop is because this patient has a 50% risk of dying. I said, sure, it has a 50% risk of dying, but we have published 15-year survival in these patients of 45%. So this means that you're excluding a number of patients because the reality is that there is gaming. Of course, it's gaming at a very high end of risk, and that's one of the possibilities of gaming.
I'm going to have to come back on that one, because I think I would fully accept that the way we do our public reporting is not right. Yeah. I fully accept that, and I agree with those points that you make, absolutely, and we need to evolve our methodology on that line.
We have no time for... There's one... Sorry to interrupt this very important and very interesting discussion, but I want to call the last presentation now about the Euroscore 2, and the presentation will be given by Dr. Rock, I guess. Perfect.
It is a burning issue, as you noticed, and it's difficult to replace Sam Neshev. And I try, after such brilliant presentations, to speak about the Euroscore 2010 trial. And the title of the presentation is a recalibration of a risk score. Risk score helps the physicians to guide him to offer the best treatment for the patients. It helps the patients to give him the informed consent, and it helps both of them. And the fact that on prognostic grounds it's important to have the information of weighting the risk of the intervention versus the risk of no intervention. Risk score is an integral part of the measurement of quality outcome. A risk model gives a predicted outcome. It can be statistically compared to actual outcome, and hospital unit surgeon finally know, or seems to be about to know, how they are doing. The first experience of the impact of measure of performance on the performance itself came from the Hawthorne General Electricity Company in Chicago. And this is a rather old experience, since the experiment was done in 1924 to 1932. One of the first questions was, do the workers perform better with more light? So the light was increased, the performance measured, and the performance improved. Second question, so do they perform worse with less light? The lights was decreased, the performance was measured, but the performance improved. And then other manipulations were done about the temperature, about the position of desk, the order of task, all meaningless changes, all followed by the performance measures, and the performance always improved. So Henry Landsberger, later on in 1955, called it the Hawthorne effect. Performance trend to improve when it is measured. Because of the awareness of the measurement, the awareness of the interest of being shown in performance, and the existence of comparative informations. And I may agree with the precedent discussion that there may be side effect on this issue. Is there a Hawthorne effect in cardiac surgery? Since the publication of the Euroscore in Europe, cardiac surgical mortality is more than halved despite older and sicker patients. The greatest improvement was seen in countries with most robust monitoring, like, for instance, in UK. We've been discussing about this just a few minutes ago. There is not very good evidence, but obviously there are other reasons that it is possible that the Hawthorne effect play a role in the improvement of performance of cardiac surgeons. So all measurement of outcome enhance performance. All measurement of outcome must be related to case mixed. All risk model scores on that front to improve performance, deliver safe care for patients, monitor outcome, identify underperformance, and do something about it. Any model will do. But for the individual patient, none of the model will do. They are wrong in 100% of time, whatever the model you use, because for a patient, either he lives and there is 100% survival, or he dies, there's 100% mortality. No model can predict either outcome with 100% certainty. So two factor matters in the use of risk models, its usability and its accuracy. On the usability side, it must be simple, objective, quick, few risk factors, easy to calculate. On the accuracy, you may have as many risk factors as possible. The interaction within risk factors must be analyzed with sophisticated tools like logistic regression model, Bayesian model, even neural networks. To assess risk model, there are two issues also, the calibration and the discriminations. And the calibration, suppose the model predicts 5% mortality. If the mortality is 4.95, there's a good calibration. If the mortality is 75, there is poor calibration. Discrimination is how good is the model to distinguish high risk from low risk. Testing a model for calibration, if the predicted outcome, you've got the predicted outcome, you've got the actual outcome. If the actual outcome is in the 75 range of the confidence interval, the model is well calibrated. If it is not, it is poorly calibrated. But the calibration is not enough. Suppose a proposed model for cabbage population to have red hair. You apply it on thousands of patients, and you can notice that red hair is present in 1.84% of patients, and the mortality is 1.85% of the population. So is the model good? No, the model is not good, because no patient who died had red hair. It means that you can have excellent calibration, very poor discrimination. Test the discrimination, use the error on the receiving operative characteristic curves. It tests sensibility against specificity. In other words, it compares randomly selected pairs of good versus bad outcome. How often does the model assign a high risk to bad outcome? Finally, excellent discrimination is obtained if the error in the ROC curves is above 1.8. Paper assessing risk models sometimes, but often, come from a single institution with a rather small number of patients and rarely address discriminations. And the model sets a standard against which some centers will perform well, and they will say that the model overestimates risk, and they will have a tendency to present their paper and submit them to publications. Where some center will be in the average, and some will do worse, and they won't be very keen to present their results. So there is a bias selection saying that the model is overestimating risk due to publication. So if you compare the two major models for cardiac surgery, the ESTS model and the Euroscore logistic, STS is comprehensive. There's some online calculators. It supports a number of interventions with different models for each of them. Ask many questions, more than 50. It is reported to be extremely accurate and regularly updated. The logistic Euroscore is also comprehensive. Has an online calculators, support all cardiac surgery operation in one model, ask a few questions. It is reported to be recently inaccurate in calibrations, but it is now been updated. Regarding discrimination, most of the publication for BOSS model shows a very good discrimination power. That there is a recent paper from Virginia comparing Euroscore, logistic Euroscore, and STS Euroscore, STS model, and showing that there's no statistical difference in the discrimination of BOSS model on the US population. So what's the aim of the Euroscore 2010? Recalibrate the model. Calibration study indicates that there's a need for the model to be refreshed. So new data have been collected on consecutive patients for all major adult cardiac surgery from May to July 2010. There's an online data collection. It takes less than 5 minutes to collect the data for a patient. The discrimination, hopefully, will also be improved. We won't use cutoff point level for continuous variable, for instance, for PA pressure, maybe for ejection fraction, for recency and size of infarction. There should be a bit of reflection of the size and the complexity of the operation than in the initial Euroscore model. Clearance will replace absolute serum creatinine, and more sophisticated appraisal for risk factors interaction should be used, like logistic regression, possibly neural networks. So where are we now? There were 500 expressions of interest, more than 200 registered units coming from 50 countries, and more than 20,000 cases already entered on the website. The website is still open. If surgeons are still interested in the Euroscore, and if they have the information from the period for May to July 2010, they can feel free to go to log on the Euroscore website and to participate in the study. Website will be closed in about 3 months. Data will be cleaned, error-checked, and validated, and the project group and statistician will begin to work on the new model. The aim is to present the result of this study at the AACS meeting of September 2011. Thank you for your attention.